attend RSNA 2023, our industry influencers and radiology trailblazers are set to help you embrace what's next in medical imaging. Imagine what new medical imaging practices and technology can teach about collaboration and innovation. We have everything you need, all in one place as we help you explore how to lead through change. Join us November 26th through the 30th for the biggest week in radiology, in person, virtually, or both. Early bird pricing is available through October 4th. Register now for the RSNA 2023 at rsna.org/register.
Hello, and welcome to the RSNA RadioGraphics podcast. I'm Lisa Blacklock, a nuclear radiologist in New Mexico. Today, we'll be talking about FDG PET-CT-based response assessment in malignancies, a recent radiographics article that reviews assessment of treatment response using PET-CT imaging, particularly in the setting of FDG-avid lymphomas and solid tumors. One of the most commonly used PET radiopharmaceuticals is 2-F18-fluoro-2-deoxydeglucose, better known as F18-FDG, a radioactive glucose analog. A basic understanding of physiology and pathophysiology involving FDG is important, since it may inform our understanding of response, potential confounders, and false positives and negatives. As a glucose analog, FDG is often used in imaging and malignancy, since many malignancies use glycolysis, even under aerobic conditions. This is known as the Warburg effect, and results in the high glucose utilization of many tumors. It's important to remember that not all tumors are FDG-avid, and that other processes, such as infection and inflammation, may also have high levels of glucose utilization and FDG uptake. These can confound assessment, particularly in the setting of post-treatment inflammation. As you may know, in oncology, the term response is typically used to refer to a favorable outcome, and progression is typically indicative of an unfavorable outcome. As the authors note, favorable response may include survival benefit, control of tumor growth or distant spread, prevention of tumor-related adverse effects, and/or improvement in quality of life. In radiology, control of tumor growth is something that can be objectively measured, but there are some limitations in response assessment that's based solely on tumor size. Potential limitations to size-based assessment of response include non-measurable disease, for example, malignant ascites or pleural effusions and sclerotic bone metastases, and tumors that typically don't respond with size change, for example, gastrointestinal stromal tumors, which initially respond with enhancement changes in hypoattenuation. Another potential limitation is immunotherapy. We're learning that traditional size-based criteria may not be adequate in the setting of immunotherapy or targeted therapies. Functional imaging with FDG PET-CT provides some advantages. For example, changes in tumor metabolism may precede structural changes, allowing for earlier response assessment. Additionally, functional imaging can be helpful to distinguish viable tumor from fibrotic lesions, such as seen in the setting of Hodgkin's lymphoma. Semi-quantitative measurements of FDG F18-FDG uptake can be obtained using standardized uptake values, or SUVs. With care to avoid confounding factors as much as possible, these values can serve as a useful measure of activity to compare baseline and follow-up imaging. This radiographics article includes assessment criteria for FDG-avid lymphomas and solid tumors. It provides multiple teaching points on response assessment and summarizes requirements for performing response assessment using PERSIST 1.0 criteria, noting potential confounders. There are multiple helpful tables summarizing the Deauville scale, the Lugano classification, and PERSIST-based response assessments, as well as associated CME questions, and I'd encourage you to review this useful resource. For this podcast, we'll be focusing on lymphoma and immunotherapy with a brief discussion of PERSIST 1.0 and some potential pearls and pitfalls. When assessing response in FDG-avid lymphoma, it's important to measure background mediastinal blood pool and background liver activity, as these are used for comparison to disease activity when using the Deauville 5-point scale. The Deauville scoring, for those that are not familiar, is as follows. A score of 1 indicates lesion uptake similar to or lower than background tissue uptake. A score of 2 indicates lesion uptake less than or equal to mediastinal blood pool. A score of 3 indicates lesion uptake greater than mediastinal blood pool, but less than or equal to background liver. A score of 4 indicates a lesion with uptake moderately higher than liver uptake. And a score of 5 indicates markedly increased lesion uptake and/or new sites of disease. It's been suggested that lesional uptake 2 to 3 times higher than the SUV max of normal background liver be considered markedly increased. The authors provide a summary of the Lugano classification of tumor response, which uses the Deauville scoring, with a complete response defined as a Deauville score of 1 to 3, so less than or equal to background liver uptake, in a patient with no new lesions and no bone marrow involvement. One important point is that some sites, including Waldeier's ring and activated bone marrow, may have physiologic FDG uptake greater than the mediastinum or even greater than the liver. This is especially true when bone marrow is affected by colony-stimulating factors. The authors note that complete response may be inferred if the post-treatment uptake is normalized and similar to surrounding tissue, even if it's higher than the mediastinum and/or liver. In contradistinction to this category, a patient with a Deauville score of 4 or 5, so activity greater than background liver, with increased activity from baseline, new or recurrent sites compatible with lymphoma, or appearance of bone marrow involvement would be considered to have progressive disease. Progressive disease may be deemed even with only one new lesion or node if this new site is compatible with lymphoma. So it's important to be sure that this is not called erroneously. As we previously noted, potential confounders can include reactive nodes or marrow activity caused by colony-stimulating factors. So it's important to make sure that any new site of suspected progression is compatible with lymphoma. The other two categories are partial response and stable disease. A patient with a Deauville score of 4 or 5, so greater than background liver, with reduced activity from baseline and no new lesions would be categorized as having a partial response. Stable disease would be deemed if the patient had a Deauville score of 4 or 5 without change in uptake from baseline and without new lesions. Regarding immunotherapy, there's a growing understanding that tumor size measurement alone may not be a good marker of therapy effect in patients receiving immunotherapy or targeted therapy agents. Since immunotherapy uses the patient's immune system to work against the tumor, different patterns of response can be seen. These include durable response, favorable response after initial apparent progression, rapid progression, and dissociated responses. Pseudoprogression is an important pattern to know, although it's relatively uncommon. Patients with pseudoprogression may demonstrate an increase in size or activity of disease and may even develop new lesions. Clinically, however, the patient may have a discordant improvement. Since patients with pseudoprogression may benefit from continuation of this therapy, with subsequent improvement in disease despite initial apparent progression or pseudoprogression, repeat imaging after at least 4 weeks may clarify. At 4 to 8 weeks, repeat imaging can help distinguish initial pseudoprogression from true progression. An additional pattern that can be seen with immunotherapy is that of hyperprogression. This is more common, reported in 4 to 29% of patients taking immune checkpoint inhibitors. It's important to know that it's associated with clinical deterioration, and therapy should be stopped. Some of the criteria noted in the article include a greater than 50% increase in tumor burden, treatment failure in less than 2 months, and an increased rate of progression greater than 2-fold. Dissociated response is also worth noting, with possible mechanisms including heterogeneity of disease, synchronous malignancies, and resistant tumor clones. While this can be seen with traditional therapy, acquired resistance to specific immunotherapy should be considered when seen in the appropriate clinical setting. PERSIST 1.0 makes use of different semi-quantitative measurements of activity than the Deauville scale. SUL peak is a standardized uptake value normalized to lean body mass, hence the SUL, as measured in the most avid 1 milliliter volume of tumor. This differs from SUB max, which is based on a single voxeler pixel and is corrected for the patient's body weight rather than lean body mass. Measurements of background liver activity using a 3 centimeter diameter spherical volume of interest in the right liver is recommended for PERSIST 1.0. For this purpose, the SUL mean is used, giving a measure of the mean uptake value of the entire spherical volume. This, like SUL peak, is also corrected for lean body mass. If the liver cannot be used due to disease involvement, then mediastinal blood pool within the descending thoracic aorta may be used. It's also interesting to note that PERSIST 1.0 does not require measurement of the same lesion at baseline and follow-up. Instead, the most avid lesion in each study is measured, and activity levels of the most avid lesion on each study are compared. In order to achieve partial metabolic response, a minimum of 30% reduction in activity is required, as well as a minimum absolute decrease of 0.8 units of SUL peak. This is helpful to prevent overinterpretation of response based on small changes in activity. Similarly, in the absence of new lesions, progressive disease would be defined as greater than or equal to 30% increase in activity, and an absolute increase of at least 0.8 units. In addition to avoiding overinterpretation of small activity changes, it's important to note the potential confounding effects of chemotherapy and radiation. The authors cite recommendation from the Consensus of Imaging Subcommittee of International Harmonization Project in Lymphoma regarding timing of follow-up imaging after treatment. Recommended periods of waiting for PET after chemotherapy and/or radiation are provided, with post-chemotherapy waiting period of at least 3 weeks and preferably 6 to 8 weeks, and a post-radiation waiting period of 8 to 12 weeks. These recommendations are in an attempt to minimize effects of therapy-induced change. The 3-week waiting period can be challenging in the setting of ongoing therapy, and the authors also note a recommendation for 10 days after chemotherapy, which is also the recommendation of the European Association of Nuclear Medicine, or EANM. I hope you found this discussion of the recent RadioGraphics article, FDG PET CT-based response assessment of malignancies, useful. Thanks for joining this RSNA RadioGraphics podcast.